Program of the Robert Wood Johnson Foundation and Director Emeritus of the McCall Center for Healthcare Innovation at the Group Health Research Institute. The goals of this webinar are on the slide. It's to discuss a little bit the importance of team involvement in patient care, especially in primary care, describe the LEAP project and some of the major lessons learned, but spend most of our time introducing you and hopefully the world to the Primary Care Team Guide, a practical web-based guide to better care through teamwork that summarizes a lot of what we learned from the 31 LEAP sites. At this point, let me turn it to the Deputy Director of the program, Brian Austin, to give you a little advice on how this webinar is going to unfold.
Thanks, Ed. Yes, I want to do just a little bit of housekeeping. What we've done is we've muted all the participants except for the panelists. And we're asking that as questions arise, you give them to us via the chat function. We'll answer as many as we can throughout the course of the webinar. And we will be giving contact information, and you'll always have the website information if your question doesn't get answered on the call. We'll also be recording the webinar, and we plan to make it available either on Improving Primary Care or on mccallcenter.org. So if you join midway, you won't lose track. Thanks very much, and now it's back to Ed.
Thanks, Brian. Brian and I will be joined on this call by co-collaborators in the LEAP project. Margaret Flinter is co-director of LEAP and Senior Vice President and Clinical Director of Community Health Center, Inc., which serves a federally funded community health center serving 130,000 patients in the state of Connecticut. Margaret is a family nurse practitioner and one of the founders of America's first nurse practitioner program. We're also joined by Tom Bodenheimer, a professor of family and community medicine at the University of California, San Francisco, a general internist, influential author, and one of the country's foremost experts in the design of primary care. We'll also be joined by Lisa Letourneau, a physician and executive director of Maine Quality Counts, an independent, multi-stakeholder regional collaborative dedicated to transforming health and healthcare in Maine. Tom and Lisa are members of the LEAP National Advisory Committee. We're also joined by Mary Joan Ladden, a nurse practitioner and senior program officer at the Robert Wood Johnson Foundation, whose work has focused on improving healthcare quality and safety through health professional collaboration. Mary Joan is one of our project officers and the brains behind this national program. Joining her will be Nancy Fishman, another senior program officer at the Robert Wood Johnson Foundation in Research Evaluation Learning Unit at RWJ. She, too, is program officer for LEAP and several other Robert Wood Johnson programs. With that, let's begin. We're going to run this webinar, hopefully, as kind of a panel, discussing teams, discussing LEAP. So let's first talk about the project PCT LEAP. The goals are on the slide, and let me turn it to Mary Joan Ladden, our project officer, to describe a little bit the impetus for LEAP. Mary Joan?
Thanks, Ed, and welcome, everyone. Several years ago, when I think the Affordable Care Act was just in nascent form, when we were thinking about it nationally, and we were thinking about the implications here at the Robert Wood Johnson Foundation for improving health and healthcare nationwide, And we looked at what the Affordable Care Act would bring, a demand for more primary care providers and a demand for more creative ways to deliver primary care. And then there was a lot of literature at that time about a shortage of primary care providers, perhaps a shortage in particular areas of the country, not necessarily in every area. So we started thinking about what could we do as a national philanthropy in this space to make an impact now, not necessarily 5 or 10 years from then as we were planning this, but what could we do now? And we settled on the issue of how can we creatively use the workforce to improve access and quality and control costs. With the Affordable Care Act and millions coming into healthcare and the need for primary care and spotty shortages across the country, we felt that a lot more could be done to utilize physicians, other clinicians, community health workers, medical assistants, and we saw bright spots across the country, but we also saw that there was not a real collection of evidence or research or site visits to really look at what were people doing, shining the light on different practices in different types of settings and different types of configurations across the country. What were people doing, and how could we spread that and create a toolkit that others could use to improve the way that they use the workforce in primary care? Hence, LEAP came about.
Thanks, Mary Joan. And so the goals of LEAP are on this slide. It was to use reputational sampling, talking to hundreds of experts in primary care across the country, asking them to nominate innovative, highly effective practices. And our National Advisory Committee and colleagues at the University of New Jersey Medical School helped develop evidence and review that evidence to ultimately choose 31, actually 30, but we've added one site because they were just site visited by too many people. We site visited each site for 3.5 days, summarized what we learned, try and have put it as best we can with tools in a web-based toolkit, which is what this webinar is about, and now we're in the process of disseminating the guide to practices, starting with practices that are involved in learning communities. But a more fundamental question is why this emphasis on teams? And on this slide, we've summarized some of the arguments that are being made for this emphasis on team-based care and building effective teams. Mary Joan mentioned that this is certainly a major impetus has been this concern about the pending shortage of primary care. And our NAC chair, Dr. Tom Bodenheimer, has thought long and hard about this issue of the relationship between team-based care and freeing up provider time. Tom, what are your thoughts?
Well, thank you. It's a crucial question. The answer is, in short, and I'll give some evidence briefly, care teams can free up provider time, but they don't always succeed in doing so. So it means that you really have to think about, like, how do we really free up provider time or increase capacity to see more patients without any more provider work? So let me give you 4 examples that I think are helpful. One is health coaching. So we did a study of medical assistants as health coaches, and the providers that they worked with reported that they spent less time with their patients. These were patients with diabetes, hypertension, and or hyperlipidemia. The providers spent less time with their patients if health coaches were involved. So that's a team-based way to reduce provider time. The second one is Clinica in Colorado has RN visits, they call flip visits, which the RN does the patient visit and the provider comes in at the very end so they can bill for it, and the provider spends a very small amount of time in the visit. And their capacity to see more patients increased by 17% at a pilot site doing this. So it means that a clinic can see more patients without providers having to see all of them. So in a sense, it increases capacity without increased provider time. A third example is complex care management. Having a complex, high-cost patients managed by a nurse-led complex care management team can save provider time because providers spend a lot of time with these high-cost, complex patients. If you have a team, it really saves a lot of provider time. There's no good research evidence on this, but there's a lot of anecdotal evidence. And then finally, and this one is the one that I think is the most interesting, team documentation, which is popularly known as scribing, is a very good way to use your team to reduce provider time. So there's a lot of anecdotal evidence from Peter Anderson's previous practice in Virginia, from a Sutter healthcare practice in California, from the University of Utah practice, that all claim that scribing saves physician time. And now we actually have a study which was done by David Rubin in Los Angeles. It was published in JAMA Internal Medicine in July of this year, showing that scribing actually saved internists 75 minutes per 4-hour clinic session. A lot of time saved. So that's a team-based a change that really can save provider time.
Thanks, Tom. While I've got you, the next is that practices with effective teams and teamwork have a tendency to report higher provider and staff satisfaction and less burnout. You just finished a little study of so-called joy in practice. Is this consistent with what you found?
Well, actually, at University of California, at our Center for Excellence in Primary Care, we've done actually a couple of studies, surveys of providers to see about whether team-based care reduces burnout or not. And this was a survey of about 300 providers in safety net clinics, in VA clinics, and in university-run clinics. Very interesting that providers working with the same MA all the time, so that we call that a stable teamlet, provider MA always working together, those providers had less burnout than providers who were working with a different medical assistant every day. So the ones that really had a structured, stable team had less burnout. There was an exception, which is that if the team culture for that teamlet was low, and by team culture we mean how well do people work together, then provider burnout did not go down, which kind of makes sense. So if you have the team structure and a reasonable team culture, burnout will go down. And then we did a follow-up study looking at the role of medical assistants doing panel management, making sure that all patients have their kind of algorithmic, preventive and chronic care tasks taken care of without necessarily having providers having to do that. We found that providers working on a team with a medical assistant doing panel management had reduced burnout. And they also responded favorably and positively to the statement, primary care is more doable job in my clinic this year as compared with last year when we didn't have the MAs doing panel management. So these are enough examples of that if you have a good team structure and you have a good team culture, you really can reduce burnout.
Thanks, Tom. In the group health medical home demonstration, evidence of reduced burnout was that a couple of physicians actually tore up their resignation letters after becoming a medical home. In our work with 65 safety net practices across 5 states trying to help them become medical homes, we held a meeting of all the practice coaches asking them what were some of the critical differences between those practices that were successful in making the transition to a medical home versus those practices that were not. And a recurrent theme was that the practices that were able to make the transition had built effective teams, and that teamwork was viewed as critical to bringing on the new sort of functions that are associated with being a medical home, like care management, care coordination, referral management.
Yeah.
Referral management and functions like that. Lisa Letourneau has been running collaboratives in New England for I don't know how many years, Lisa. Does teamwork appear to be a critical sort of step on the route to making the changes to becoming a full medical home?
Hi, Ed. Absolutely. Although I wish you wouldn't make it sound like so many years, because I feel like I'm really old when you say it that way. But yes, I have had the benefit of working with very hardworking primary care practices for many years now in Maine. And I think absolutely that is an absolutely critical piece and a common thread of those practices that we see doing the best in this work. And very much to some of the points that Tom has made so well and researched so nicely in terms of avoiding burnout and supporting the teams and increasing their efficiency. I think he has the benefit of seeing that empirically. We have the privilege of seeing it play out in many practices around the state, including, we're very proud to say, 2 of the sites that were featured in the LEAP case studies, Penobscot Community Healthcare in Bangor and Martins Point Healthcare in Bangor. I think are great examples of that, and we have several others in the state that you absolutely see that common thread. You know, we often reflect that we've worked with so many practices. We have about 200 right now involved in our medical home, primary care medical home, health home efforts. And at the beginning of this work, we often heard some practices say, well, you know, I can't do this because, or the other guys can do it better than me because they're big, or because they're small, or because they're an FQHC, or because they're hospital-owned, or because they're not hospital-owned. And after we heard this for a while, we realized, you know what, there's really no one characteristic of ownership or size or payment source that absolutely defines the ability to do this work. It is far more about leadership and a commitment to really developing the potential of the team within those practices. And I think the ability to be part of the SLEEP initiative and learn from the other practices that have been highlighted as part of the 31 case studies has just completely reinforced that for me. And I think is a huge and critical learning if we're going to be able to move forward and help with practice transformation on a wider scale in our state and certainly nationwide.
Thanks, Lisa. And then the last why is because there's strong evidence, in my view, that it's evidence-based. In several meta-analyses of interventions that improve outcomes of chronic illnesses in primary care, the involvement of the non-provider members of practice teams actually in patient care, in delivering chronic illness care, has proven to be one among the most powerful interventions for achieving the control of major chronic illnesses. And those people who have been studying what leads to better performance metrics around prevention will all tell you that it's involving the team in the delivery of preventive services that makes the biggest difference. So this is, if anybody on the webinar has a question around why teams, we'd love to hear it.
And use your chat function. And Margaret, if you've joined us, if you can say hi over the line, that would help us. Okay, we'll keep trying.
All right, so a little bit more about LEAP and what we've learned. Firstly, just a picture of where the sites are, and as you can see, they're scattered across 20 states. With a heavy concentration on both coasts. And let's talk now about some of the major findings. not surprisingly, because we selected the sites because they were innovators in the development of effective teams, the sites, without exception, had well-developed what we call core teams, surrounded by a more extended team that consisted often of nurse care managers, sometimes pharmacists, often behavioral health specialists, and occasionally other professionals like social workers and the like. We were also struck by how frequently sites, and not just safety net practices, involved laypersons and flow staff, medical assistants primarily, playing key patient care roles. Most practices had this. Roles like self-management support, patient navigation, outreach, and so on. We are often asked, what does a primary care team look like? And based on what we saw in the 31 LEAP sites, we've developed this simple diagram. When we talk about the core primary care team, we're really talking about those staff that are involved with specific providers and their panels and patients. This can be, a core team can be as small as one provider and one flow staff, one medical assistant, Tom Bodenheimer's teamlet, but core teams among LEAP sites sometimes included 3 or even 4 primary care providers surrounded by 3 or 4 medical assistants, a registered nurse, maybe a health navigator or health coach or 2, and so on. And then the extended care team, as I indicated, are usually centralized staff that are serving all of the providers and core teams in that particular practice. Another key finding is that sites achieved their high levels of performance by effectively performing critical primary care functions, such as planned care, population management, care coordination. That was how teams achieved the outcomes, the improved career satisfaction, patient experience, et cetera, that they were achieving. And that has led us to sort of think about this business of how do primary care teams, how do patient-centered medical homes achieve the triple, or as Tom has recently written, the quadruple aim of improved health, improved patient experience, reduced total costs, and improved staff experience. You're all familiar with the elements. Tom has written about the building blocks. We talk about change concepts associated with the patient medical home. Those are largely describing the infrastructure and capacity within primary care that enables, of which teams are, effective teams are a critical element. But what's in the middle are these critical functions. And we spent a lot of time in our site visits trying to understand and describe how LEAP sites deployed their staff to perform these critical functions. And this played a very important part in the design of the primary care team guide. Any questions about why teams or what we learned from LEAP?
Right now, the chat line's quiet, so we've either put them to sleep or answered all their questions.
Well, let me pose to our panel some of the questions that, as we've been presenting this work, have come up repeatedly. Let's start with the question of, do you have to be a large practice organization to achieve all of this? Could a small practice with 1 or 2 providers actually do this? Anybody want to tackle that one?
Sure, this is Tom. I'll give it a try. I think by itself, a practice with 1 or 2 providers and maybe a couple of medical assistants and a couple of front desk people could not do all of this. But they're increasing, these small practices are working together with larger organizations. They could be independent practice associations, which could provide like nurses for care management, for complex care management, could provide registries and help for panel management and so forth. Or if it's a hospital-based system, the hospital could help the practice do that, or several practices could get together. Like, for example, North Carolina Medicaid, they have these very small practices, and they've set up a whole system of nurse care managers at different parts of the state to support small practices. So I do think small practices can do it, but I don't think they can do it by themselves.
I've shifted back to a previous slide to show you that what Tom is talking about is we've tried to capture in that blue ring because we saw often that LEAP sites were taking advantage of staff that were really employees or related to other organizations, whether it's the health plan or a local community mental health center, academic institution, whatever. Another question that comes up is this issue of lay persons. And lay persons are generally, I mean, I think when you say lay persons in primary care, most people might think about federally funded community health centers and community health workers. But we saw them in all different roles and practices. What are some of the potential of using lay people in primary care? Anybody want to tackle that one?
I mean, I'm happy to again, though I don't want to talk too much. This is Tom. We did a randomized controlled trial of, we recruited about 40 low-income patients with diabetes to be health coaches for other patients with diabetes. And the patients who were linked to one of these, what we call peer health coaches, had better improvement in their A1C, statistically significantly better improvement than the control group that did not have peer coaches. So you can use lay people as health coaches, and especially if they have the same disease as the people they're coaching, it makes it extremely meaningful.
And recently, in the Annals of Internal Medicine, there was a large randomized trial from the Allina organization in Minnesota that developed another lay role called Care Guides that provided some self-management support, some care coordination, and some sort of just information transfer. And these were deployed in commercial practices, not in safety net practices, and they showed significant improvements in the achievement of chronic care-related goals in these patients. There are other studies where lay persons are called health navigators or patient navigators that work primarily around linkages with community resources and care coordination activities that have also been shown to be successful. Any other thoughts about the use of lay persons?
Well, Ed, it's Margaret. I finally have my audio straight. And I would just add to that I think that if we look forward, this is one of the areas where we're going to see the most change over the next couple of years. And what we heard at a lot of sites was that in their states in particular, there was sort of a new emergence of focus on community health workers as part of that lay health worker team, often through the community colleges and through community development programs. So I think we're going to probably see one of the greatest areas of continued sort of growth and development in that as a member of the team going forward.
Thanks, Margaret. I'm glad you finally got the audio worked out. And of course, the question that we probably get the most often is, how do these practices pay for the infrastructure that is associated with building an effective team? And I'm going to turn to Lisa, because Lisa has worked hard in Maine to link transformation with payment reform. Lisa, what do you see?
Well, Ed, as we've talked about before, I think that we have to recognize that practices are working in some ways at least two, and in some ways many different payment environments right now, and a payment environment that's rapidly changing. But the good news is I think that this kind of change that improves not only the efficiency of the practice team, but ideally the vitality and sustainability of practice teams, staff, and providers is both essential and can be done in both of those worlds. Clearly, the ideal would be moving, as some practices are fortunate to be doing, to a payment system that is less connected to the hamster wheel fee-for-service payment methodology, where practices are paid in a partial or full primary care capitation and have the full latitude to use those resources in whatever way best supports their team, and to organize their team in a way that isn't dependent on the 99213 visit code over and over. Some practices are fortunate enough to have those kinds of payment arrangements already, and that's great, and we think that many of them will make great strides in rearranging their teams in this way. That said, we know there are other practices all the way at the other end on straight fee-for-service. So again, I think those payment arrangements are all, those worlds are rapidly changing. And then we have many in the middle, right, where they're getting paid mostly fee-for-service, but have some non-visit-based payment sources, maybe like medical home payments or some incentive bonuses. And I think that there are mechanisms, even in those worlds, to support these kinds of teams, starting with improving the efficiency of the team. I've heard, many practices that have been successful in making these changes make the argument that it doesn't take many more visits. Now, nobody wants to just talk about increasing volume, but if you can improve the efficiency, unload the provider, and make that provider more productive in his or her interaction, it doesn't really take that many more visits on a daily basis to make up the salary of an additional medical assistant. If you figure that medical assistants are paid, somewhere in the order of maybe $30,000 to $40,000, when you take salary and benefits together. Now, you could also argue, from a social justice perspective, should we be paying those staff more? But in the current payment ranges, that's probably what it is. So if you do the math, oftentimes it comes out to something on the order of, an additional 1 to 2 visits a day, depending on the environment and the payer mix. The other math that I think needs to go into the equation is, what does it cost to replace a provider, a physician, NP or PA, who's burned out and can't take it, one more day? And I've heard estimates of upwards of $200,000 to $400,000 to replace a provider in terms of lost productivity, training, recruiting costs. So again, do the math on that. How many MAs can you hire for that? The other reality is that there are newer payment mechanisms that may not be perfect, but can be leveraged using a team-based model to capture some additional revenue, starting at really even thinking of, in the Medicare world, of things like the annual wellness visit. So I've seen teams that have organized their staff to use nursing staff to prepare a patient for an annual wellness visit, use a very focused, highly efficient time with the provider to be able to bill appropriately for that, and capture significant revenue from being able to bring in Medicare patients and do appropriate care using that wellness visit code. There are also the newer codes like care transition codes that, again, can be captured. I know there's administrative challenges to that, but revenue can be captured. And then most recently, CMS has just introduced, we're all watching with great interest, the new chronic care management code that's being introduced in the calendar year 2015 physician fee schedule, available to any provider paid on the physician fee schedule. Unfortunately, right now, not FQHCs and rural health centers, but certainly provider-based and freestanding primary care practices. There are admittedly a lot of challenges, I think, for practices to make sure that they're delivering the services required of the chronic care management code, including things like using electronic shared care plan and providing 24/7 access to care. But I think a well-organized practice, particularly one that's been developing their capacity around medical home type of functionalities, could be in a position to bill for those services, and those are specifically non-visit based services. So if people haven't seen that yet, we've got some information posted on our Maine Quality Accounts website, and I'm sure more will be coming out from CMS soon, but it allows eligible providers to bill. It's roughly $40 per Medicare patient per month for delivering up to 20 minutes or more of non-visit-based care management services. And again, using your team, and that absolutely can be other members of the team delivering that service. That's not even necessarily a physician or incident to a physician on site. So again, I think that's kind of a long answer, but the short answer is that there are ways, even within the current admittedly broken payment system, to take advantage of the payment sources already available, then with an eye towards really creating that more organized, functional, efficient team that will absolutely be needed and will be able to benefit from newer models of payment as we evolve towards those.
Thanks, Lisa. There is hope.
There is hope, absolutely.
And now we want to introduce you more formally to the Primary Care Team Guide. As I mentioned earlier, it is really structured around that little flow diagram that goes from structure to functions to outcomes, because it's really divided. The Primary Care Team Guide is organized in 3 sections. One, getting started, which is really around the basics of teams and team building. Second is around the people, those roles that are a critical part of the primary care team, and then the work, which is the functions that we described on that slide. I'm going to turn it over to my colleague, Brian Austin. Brian?
Thanks, Ed. And let me start by giving credit where it's due and thanking Pyramid Communications here in Seattle for building the site with us. It looks more beautiful than you see it on the screen now because of the compression due to WebEx. So we hope when you see it in person, you'll be suitably impressed. As Ed mentioned, we tried very hard to keep the organization simple and to put a minimum of extra text between you and what you need to get from the site. I think we're up to around 200 tools and resources on top of what we and others have written for the site. So there's a lot of content there, and we tried to put it as elegantly simple as we possibly could. As Ed mentioned, we've divided it into 3 sections, and you can see those across the top, and this bar will be there with you as you go through the 3 sections. Let's start at Get Started. In the Get Started section, we put some of what you're hearing in this webinar. We put the essentials of what people need to organize themselves to orient themselves to the site, to understand why we think an emphasis on the workforce is important, and to learn how to navigate the site and where to start. You'll notice that for here, as for the other 2 introductory sections, we have a video. We're not showing the videos today, but we recommend them because they're only a couple of minutes long, and they'll give you or someone else you direct the site to a quick briefing on the principles of team care and an overview of the LEAP program. So you'll begin, logically enough, and get started, but you'll spend most of your time in the other 2 categories. go to Build the Team. Again, there's a short video that you can watch if you like, and then below that, you'll find an introductory module on the practice team, and at this point, 5 role-specific modules. For first-timers, we would recommend that you spend time in the introductory module. I'm on Ed's computer, it's a little slow. Which provides context for this section and contains important background information on things like building a team culture, enabling staff to work independently. But after the introductory module, you'll probably spend most of your time in the individual roles. So let's go to the medical assistant, and you'll see how these modules are organized. We can look at the common structure that they share. At the top of the page, you'll find you have an opportunity to take a brief assessment, which might be 1 question, as in this case, or as many as half a dozen, depending on the module. These are based on questions from the Patient-Centered Medical Home Assessment, which, as Ed mentioned, was developed for the Safety Net Medical Home Initiative, and it's been augmented with questions from Tom Bodenheimer's Building Block Assessment, and then some custom ones we've made. There's also a link to take the full assessment, and that will be a compilation of all the questions from all the modules. So here's the format that every module shares. After the overview, which will explain what needs to change for each topic area and what can be gained by making the changes, we've put a series of discrete action steps. And this is really part of the heart of the website. For each action step, you can easily get to the most relevant tools and resources with a single click. So you can see for medical assistant, we've got a total of 6 action steps, from select a model through provide a career ladder and opportunities for growth. You can expand the resources for each of the action steps and get to the specific tools. In this case, the Care Team Medical Assistant Training Curriculum, which has been provided to us from West County Health Centers. And you can see that that's a MA orientation that goes into quite a bit of specificity on team roles, managing the patient office experience, organization of the team, and specific workflows. Okay. Got a question, Ed?
We have a couple of questions. One is, did the 31 site visits note any consistent downside or negative outcomes to high-functioning teams? People talked about the challenges in creating and sustaining high-functioning teams, but I cannot honestly recall a negative outcome from having moved the practice in that direction.
The only one I can think of is people did say their staff were more likely to get poached because of the time they had spent on high-functioning teams and the desire of other community providers to maybe share in that without going through the whole training process.
Anybody else on the call, because we have other site visitors, recall anything negative about moving in this direction?
I mean, this is Tom. It's sort of what Brian was saying. When you have teams and then you have turnover in the team members, it can be very disorienting to the team.
The second question is involving training. Training was critical, and what we heard repeatedly on our site visits was that that practices felt that it was critical that they do the training. So many of the practices had built quite sophisticated in-house training programs, and we've tried in our tools to capture those information from those training programs, curricula, training program agendas, and the like. So
new employee orientation.
Right. So training is, no question, training is a critical need, and for these expanded roles, people like medical assistants are generally not getting much training in their formal certification programs, so the practice has to increase their skill levels.
I'm going to jump back to the tour just so we make sure we finish up. You can also get, if you can go through the steps, you can also get to all the resources available for each specific module in two places. One is over here on the right side, where you can look at all 26 modules, 26 resources, for instance, connected to the medical assistant module, or you can go to the next tab over, which is tools and resources. That's organized by type of tool, so you can see we have case summaries, we have publications, we have a range of staff training tools, and so we have a real variety of tools that are available. All right, and then as promised, you have an opportunity to provide feedback. You can offer additional resources. You can ask us questions about the website, but both here and on the footer, there's an opportunity to contact us, which we'd hope you'd take advantage of. We've also, let me go back, we've also tried to link related work topics. And so we've tried to cross the roles with work topics so that if you're working in an area, you can quickly go between people and the work. Moving to do the work, right now we again have an introductory module, and at this point we have 9 topic-specific modules. As you'll see, they're everything from enhancing access, self-management support, through a range of other key functions to pursue the quadruple aim and improve primary care. The function modules are organized just like the role modules. So once you're oriented to one, you'll find the same steps. I didn't mention before, but you also have an opportunity to print a topic. So in this case, this would run to about 18 pages of text if you wanted to print out not all the resources, but all the summaries of the resources in case you wanted to pass them on to someone. So I guess a final techie note on my part, which is the website has been designed so it'll format itself to the device you access it from. So it should look good on a computer, on a tablet, or even a smartphone. As I close, I'd just like to thank all the people who contributed to the site. First and foremost, staff from the LEAP sites themselves, who taught us a great deal, and then the hardworking staff here at McCall, as well as our co-editors from our National Advisory Committee who brought it to this point. And we certainly hope to continue to improve it with the help of others on this call, as well as others in the field. So at this point, Lisa, you've lived with the site as a co-editor for a while. And you're obviously in the trenches of quality improvement and practice improvement. Can you just spend a minute giving your impressions on how it might be useful?
Sure. Well, I just think it's a phenomenal team. I think, excuse me, a phenomenal project, reflecting the work of the team and all those 31 teams that we were privileged to interview. And I just think it's a great tool no matter where you are. So, you know, again, we work with a wide range of practices doing this work, from those, including the 2 that were featured here that have been doing this work for years, to those that are really just starting. And that's what I love about this, the way it's organized in terms of you can find something to help no matter where you are. So you're early on, you start with a get started. You want to know how you can use your medical assistant more. You're working within the team structure. You want to know how we can really organize some of the work. You might be in different aspects of doing the work. And I think the cross-referencing between the team and the work is incredibly helpful because sometimes you're approaching it from one framework and sometimes from the other. And the ability to really see hands-on examples of other practices and how they've approached this is exactly what practices ask for. So I think it's easy to navigate. It answers questions for the practices. It gives them real-time, practical resources and tools. And I just think it's going to be hugely helpful.
Thanks, Lisa. Noah Nesson has made a very, very helpful comment that I hope everybody on the call can see about how when teams start effectively performing some of these functions, there is a temporary glut of new forms and new data, new things, but that does pass. Useful comment. Thank you. Any other comments or questions? We still have about 5 minutes, but I would like to turn it over to my co-director, Margaret Flinter, for her reflections on the process and where we're going from here. Margaret?
Well, thanks, Ed, and thank you to the 72 or 75 people that have joined on this afternoon. We have really appreciated you being here, and I have the honor, I guess, of being the closer, and I want to take it back to Mary Jo Ladin's opening comments about this vision that the Robert Wood Johnson Foundation and Mary Jo and Nancy in particular had. This vision informed by their own careers as nurses and nurse practitioners and researchers that primary care could be what we need it to be, that it could be this high vitality, highly effective practice, and they had this idea that we could go out and find the places across the country that were doing the hard work, often that work building on previous work, being in collaboratives, working in teams to create something that would last and that really fundamentally changed primary care practice. And I say to all of you who are on the call who were part of the sites that we visited, you know that we winnowed down from 300 practices to the final 31 practices that we visited. And in many ways, I feel like we identified some of the most creative, the most resilient, the most forward-looking practices that we could find in America, and that's what created the Leapsters, as Ed has called them, who are the culmination of this project. But I can't overemphasize how much the world changed while we were at it. And we talked about the Affordable Care Act having come along and been implemented, and I want us to just acknowledge for a moment what radical change there has been with the expansion of Medicaid in so many states across the country, with people having access to insurance through the exchange, with the focus on being able to access primary care for prevention and health promotion, changes in fee schedules for primary care, things that so many people on this call worked for so long came to fruition. But something else happened along the way too, which I think we should celebrate, and that is maybe the ultimate sign of success, that which was considered innovative and groundbreaking and cutting edge when we started the work is now, as I travel around the country, seen as almost routine, that we do practice in teams, that we have electronic health records, that we focus on population management, that behavioral health is seen as an essentially integrated function within primary care, and that the roles of people like medical assistants and nurses and pharmacists and lay people and behavioralists have all begun to garner the attention and the respect that these roles have deserved for so long. I think it's been close to 4 years probably since Mary Jo and Nancy first pulled us together, and we've seen other shifts in primary care at the same time. Quality improvement at the front line, not seen as a reporting burden, but seen almost as a virtuous science that we need to master to help us keep making our practices better and our care better. Coaches, not just for the patients, but coaches for us as the practices and as people both delivering care and people leading practices to have the advantage of a coach to help continually get better. And I don't think we've mentioned today, so I want to definitely give a shout out to the leaders that have emerged and been supported through the Emerging Leaders portion of the LEAP project. Many of them have moved around between both between LEAP practices and on to other areas, and I think we all celebrate them as the Johnny Appleseeds who go forth and bring some of these creative and innovative practices to areas that may not have had a chance to develop that so far. And with all that, new knowledge has been created. So I think we get to say, for a moment, a big hurrah, a bravo, a cheer, a well done to everybody who's participated. But as I think Brian set us up with that last piece of showing us how we can contribute to the website and to the guide, the work is not done. It's never static. I think this transformation of primary care is the work of our lifetimes for so many of us. It's work that has to continue. We are all on this big team, and what we most need from people now is to help us continue to advance and refine and expand the work. So please continue to share your feedback. It's not a static site, but a dynamic site that's been presented to you today, and your work will make it that much better. So thank you to the Robert Wood Johnson Foundation. Thank you to the panelists. Thank you to certainly all the leaders at McCall and Group Health, and to the entire team of people who participated in this project. Ed, any last words and goodbye?
No, we look forward to hearing from you, as Margaret said, as we go forward. Thanks for joining, and we hope to see you soon. Bye, everybody.
Thanks, everyone.